the Cardiac Sciences Nursing Grand Rounds. Crystal De Silva, she's one of the nurses in our ACCU. I'm Chris Kernick. Manager Roseanne Lavoisici in the back, ACCU. And so welcome to the first of a series of lectures over the course of the year from our nursing leadership. And we're going to talk today about the evolution of ACCU, past, present, and future. And of course, we have no financial disclosures to disclose to you. We do want to take some time, though, to acknowledge Dr. Alan Schaefer and Brett Hebert, our statistician, who helped to provide some of the information that is included in the presentation. So let Crystal start.
Okay. We're going to start with the history of CCU. In 1947, a pioneering cardiac surgeon named Claude Beck at University Hospital of Cleveland brings his experimental device out of the hospital basement to defibrillate a 14-year-old's heart that stopped during surgery. The single defibrillator consisted of a transformer to isolate the patient from the 110-volt AC wall supply, a resistor to limit the current, and 2 metal tablespoons with wooden handles to deliver the jolt to the exposed heart. This is an example of the open heart defibrillator. Until the mid-1950s, the only means of defibrillation was when the chest cavity was open. It wasn't until 1955 and 56 when the closed chest defibrillation was pioneered by Dr. V. Eskin in the USSR and Dr. Paul Zoll from the US, working independently from each other. They were able to successfully defibrillate patients by placing electrode pads on the chest wall itself. This is the closed chest defibrillator example. Dutch physician Willem Eindhoven is considered the father of the modern-day ECG machine. He invented the string galvanometer in 1901, and this led to the invention of the first practical ECG machine around the same time. He was also the first to coin the term electrocardiogram in 1893. Most of the working principles and methods of reading an electrocardiogram, still in use to this day, were originally conceived by Willem Eindhoven. For his invention, he received the 1924 Nobel Prize in Physiology or Medicine. The first ECG machines were very large and bulky, weighing around 275 kilograms or 600 pounds. It was not possible to bring these machines to the patient's bedside. In the early days, the hands and feet of the patient were placed in buckets filled with sodium chloride for conduction. One of the greatest innovations in the development of these ECG machines came in the 1940s with the invention of electrodes that could be attached to the skin surface of the patient. These electrodes conducted and relayed the electrical signals through attached cables to the ECG machine. Nowadays, ECG machines use disposable electrodes in the form of self-adhesive patches. The first coronary care units were established in the early 1960s in an attempt to reduce mortality from acute myocardial infarction. Pioneering cardiologists recognized the threat of death due to malignant arrhythmias in the post-infarction setting and developed techniques for successful external defibrillation. In specific, it was the closed chest cardiac resuscitation that triggered the advent of the CCUs. Thus, the monitoring of patients with MIs began early in 1962 on newly designed units. Virtually simultaneously, CCUs opened up in Sydney, Toronto, Kansas, and Philadelphia, with more to follow. For example, the 7-bed unit opened up in Kansas City, adjacent to their med-surg ICU. It opened in May 1962. The unit included continuous ECG monitoring. It had a mobile cart with an external defibrillator and nurses trained to activate the hospital CPR team and to administer CPR and defibrillate without a doctor present if they didn't arrive within 2 minutes. The development of care in CCUs included a resuscitation phase, a phase of vigorous management of arrhythmias, investigation of treatment of heart failure phase, out of hospital care phase, and a phase aimed at preventing sudden death. These are the goals of care. A rotating team of health officers would stay on the units monitoring patients. The result was dismal. The resident physicians were hopelessly bored with the inactivity. So, the job was given to nurses for detection and treatment of arrhythmias, including defibrillation, and the survival rate of patients improved from 1 to 9 to 6 of the next 15, respectively, with nursing watching. Mortality. In-hospital mortality rates of patients with MIs dropped from 30-40% in the 1950s to 15 to 20% in the 1920s after the advent of CCUs. In 1966, they started pre-hospital coronary care. Primary concern was treatment of cardiac failure and shock, rather than the prevention and treatment of cardiac arrest. And in 1967, transvenous pacing took on a rapid expansion within the CCU population. 1968, fibrinolytic therapy, streptokinase, was initiated within the first hours after onset of disease. Treatment is derived from the fact that thrombosis of coronary arteries is found to 80% of the MI patients. They would be admitted to CCU and thrombolytics were administered. Later on in the 80s, this function was transferred to emergency rooms. Newer technologies such as pulmonary artery catheterizations and echocardiography permitted assessment of patients post-MI, leading to hemodynamic evaluation, pathophysiological observations, and this allowed for better patient management by the doctors. Advanced medical technologies, including non-invasive and invasive hemodynamic monitoring tools, complex modes of mechanical ventilation, renal replacement therapies, imaging guidance for bedside vascular procedures, induction of therapeutic hypothermia, mechanical circulatory support have become common practice in CCU units. Percutaneous support measures are increasingly being used in management of acute cardiogenic shock and to support high-risk percutaneous interventions and electrophysiology procedures such as ablation therapy. Changing patient demographics. With success in management of arrhythmias and conduction disorders, the main cause of death post-MI became advanced left ventricular failure and cardiogenic shock. On the slide, you can see a breakdown of the causes of cardiogenic shock. If you can, there's tamponade rupture, 1.7%, RV shock, 3.4. We have ventricular septal defects, 4.6. Acute severe mitral regurgitation, 8.3. And then this large one is predominant left ventricular failure at 74.5%. CCU is not quite just cardiac anymore. Over the past few decades, chronic illnesses such as diabetes mellitus, hypertension, renal dysfunction, and obstructive lung diseases now commonly coexist with cardiac illness. Patients diagnosed with acute heart failure and end-stage heart failure can now be stabilized with the help of mechanical circulatory support, such as a balloon pump, extracorporeal life support, such as ECMO, pharmacological agents, which are infusions of inotropes, vasopressors, and vasodilators, and other technologies, such as percutaneous and surgically implanted ventricular assist devices, and renal replacement therapies. Patients in end-stage heart failure who are approved candidates for heart transplant often wait on CCU units with the help of advanced therapies until a heart is available for a transplant. These patients are high risk for progressive critical illness. They can develop multi or single organ dysfunction and or failure and have significantly longer lengths of stay in hospital. Furthermore, growing populations of patients with severe pulmonary hypertension and advanced structural heart diseases further expand the population in CCU. Although the rate of STEMI patients admitted to CCU has been decreasing over time, the admission rate of heart failure patients has been rising steadily. This is our STEMI, well not ours, but general stats for STEMI admissions, and then this is heart failure admission. So you can kind of see there. End-stage disease states have become commonplace in CCUs. We often care for patients with single or multiple organ dysfunction or failure. This can also progress to end-of-life care or palliation for patients on our units. Additional patient populations that we admit can include acute arrhythmias, pulmonary embolisms, we see infective endocarditis, pericardial effusions, acute thoracic aortic emergencies, hypertensive emergencies, overdose requiring cardiac monitoring, and also adult congenital heart disease with acute decompensation. Research shows that outcomes are improved when patients are admitted into a CCU post-MI with a mortality of up to 16.2% versus 32% for general medical care on a non-cardiac unit. Patients admitted under cardiology had more disease-modifying treatments prescribed and were more likely to have cardiac specialist physician follow-up post-discharge. Our CCU team, to support the development of care in CCUs, the healthcare team has expanded from nurses and physicians to include a variety of other health specialists. We have pharmacists, clinical dietitians, physical therapists, social workers, occupational therapists, and including spiritual care providers. Here's a bit of a breakdown of all of their roles. Next, Chris will talk about our local experience.
So I'll take over and talk a little bit about the history of the current unit. It was kind of hard to find exactly when our CCU opened. It sounds like it opened sort of around the late 60s, which sort of coincides to what the literature says in terms of CCUs opening in 1962, and then a very rapid sort of uptake of that worldwide, etc. And that unit, actually, it's kind of full circle now, but it was on the 5th floor on the west wing. It was a 6-bed unit, and they looked after sort of MIs, TDPs, arrhythmias, and management of those that were sort of on inotropes or inotrope holidays. And at that time, the nursing ratio was 3:1. It moved down to the 2nd floor where the current ICMS is in 1997, and remained that 6-bed unit. In 2005, it moves back up to the 5th floor, leaving ICMS to become its own unit attached to the cardiology wing, for those of you that know that. And again, we start with MIs, we continue on with TVPs, we continue to look after arrhythmia patients and inotropes, but we very rapidly expand to take in art lines, monitor CVPs, BiPAP, look after pulmonary artery catheters, and dabble in a little ultrafiltration. And the acuity changes such that we go from 3:1 nursing to a 2:1 ratio model. However, until that unit changes, there are no vasopressors except for the use of dopamine. That was somewhat used as sometimes a vasopressor and sometimes as an inotrope. And then our new ACCU, so not just a coronary care unit, but an acute cardiac unit that opens in July 5th of 2016, becoming a critical care unit with critical care nursing required, still looking after ischemic heart disease, arrhythmias, and heart failures, but now the addition of the intubated patient, vasopressors, balloon pumps, and the nursing ratio varies between sort of a 2:1, which would be the standard, or 1:1, depending on acuity. And so let's look at what sort of we've done since we've opened. So this is sort of some statistics from July 5th of the opening date to June 26th of 2017. And we can see that we did a total of 723 admissions. And of those, 29% of them come from the emergency room, 45% of admissions come from the cath lab, 16% come from other. WRHA hospitals would be 3%, and then outside of the WRHA would be about 8%. So that's sort of the breakdown of admissions as they come. And then in terms of our disposition or transfer out, 5% died, 4% were sent home, 73% were sent to the ward, meaning 5A cardiology. That was a very close relationship. 8% going to the OR, 3% ICMS, 1% to other WRHA hospitals, and then 6% that go outside of the WRHA, making that up for the total discharges. This one I kind of had to really look at this, and Roseanne will correct me if I'm wrong. This talks about sort of daily bed occupancy, and the big take home is that the average bed occupancy is about 5 out of 6 on a quick snapshot of CCU. So at any given time, if you look at CCU, 5 out of the 6 beds would be occupied in the CCU. I was talking to Dan from 5A Cardiology, and they said they have about a 95% occupancy rate. We're probably fairly close to that, but the numbers get skewed because because the number is 6 as the denominator, for those of you like math. In terms of length of stay, fascinating to take a look. Our shortest length of stay has been an hour, and our longest length of stay would be 55 days. That would be attributable to somebody who's waiting for heart transplant in the unit. Our median length of stay is 40 hours, and our average length of stay is 58 hours. So you can tell our time is very short in the unit. In terms of sort of age, we've had as young as 18 and as old as 98, with the median age being 66 years. And then you can see that we are still predominantly, in terms of cardiac care, male patients at 67% versus 33%. And you can sort of see up until the data from June, balloon pumps of the numbers in there, about 9% would be balloon pump, 14% invasive mechanical ventilation, 10% BiPAP, and then a combination, 22% taking in the invasive as well as non-invasive ventilation that would occur in the ACCU. In terms of sort of balloon pumps that we've looked at, so in terms of this data goes from July 5th to July 4th, so a little bit different than the others, but the total number of admissions, 743, and that's any patient admitted under ACCU. So if, for instance, our 6 beds are full and a patient gets admitted to ICCS under ACCU service, that accounts for those 743. The number of balloon pumps would be 69 in that time period. And you can sort of see the statistics in terms of comparing us to units that are somewhat larger than us in our 6 beds. So you can sort of see turnarounds very fast. So in terms of cardiologists and some of the challenges in terms of cardiology, there's been very little information in terms of preparation or what a ACCU should look like. So the AHA published in 2012 a scientific statement that talks about the evolution of critical care cardiology and what are some of what should be maybe staffing models and what does it sort of look like. And really what their data show or documents at is a level 3 CIC, and their definition was a cardiac ICU. The lowest level CIC would be a level 3 unit. That unit would have a patient population that looked at sort of initial diagnosis, management of common CV conditions, so relatively low complexity with potentially some respiratory failure. And then if that patient was unstable, they would be transferred to a level 1 or level 2 unit. The technology that would be in a level 3 unit would be non-invasive and some invasive monitoring, such as an art line. And then it does talk about mechanical ventilation in there. And then in terms of the physician management would be cardiology admission or consultation with an intensivist available at all times. And looking at that, their statement was an RN ratio of 1:2 or 1:3. This is probably where the old CCU on the 5th floor would have fit. And we did do mechanical ventilation, but it was non-invasive. We did BiPAP on patients. A level 2 CICU would have, again, initial diagnosis and management of most CV conditions. It might be a STEMI with primary PCI capable facility, transferred to a level 1 ICU if they remained unstable. The type of technology you would see in a level 2 CICU would be sort of all invasive or non-invasive monitoring, balloon pumps and or other non-VAD devices, coronary angiography available on site or via transfer, interventional cardiology access would be preferable, cardiac surgery access preferable, mechanical ventilation, and therapeutic hypothermia initiation. And the physician management would be an intensivist, either a cardiac or generalist, available at all times and involved in the management of patients. And the suggested RN ratios would be 1 to 1 to 1 to 3. And I'll come back to that in a moment. Level 1 CICU, your highest level, would be capable of management of all CV conditions as well as major non-CV comorbid conditions. So it would include advanced heart failure, it would be your STEMI patients, and it might include a post-CV surgery. And they would have basically the full spectrum of mechanical circulatory support, balloon pumps, might be percutaneous or implantable VADs. You can see sort of mechanical ventilation, targeted temperature management, CRRT, and the physician management would be high intensity management, where would either be an intensivist cardiac or general or intensivist consultation. So, and the RN nurse ratio 1 to 1 to 1 to 2. So this sort of in discussion with Dr. Schaefer, ICCS doesn't quite meet this because the way the scientific statement is designed is much more of a acute cardiac care unit versus being a post-cardiac surgery focus. But the current ACCU would sort of be at 1.5. It kind of fits in between where you would see the level 1. And is there a goal towards a level 1? Don't know. Have to wait for the last line on that one. So medical training. So the current preparation for medical staff would be a 3-year cardiology fellowship. If a physician is considering dual certification in terms of being cardiology and critical care, it would be 5 years of training. So a 3-year cardiology fellowship followed by a 2-year critical care. Some, such as Dr. Schaefer, would be 6 years, where you do 3 years cardiology and 3 years critical care / transplant, which is what his preparation. So of our cardiologists that attend in ACCU, he would be the only physician that would be an intensivist / cardiologist. And his training would be 6 years because he's done a combination of critical care and transplant. The U.S. is slightly less in terms of their clinical component compared to the Canadian. So not every ACCU physician is going to go down this path. 6 years might be prohibitive, they're aware of that. So collaboration is key in terms of working together with intensivists, either in ICCS or in ICMS. So we have a current automatic process. If a patient is in the ACCU and they're intubated greater than 48 hours, that is an automatic consult to ICMS for co-management or consultation. The same if there's a patient in ICMS that has a cardiac diagnosis, they too have an automatic consultation to ACCU staff in terms of consultation or co-management. And we've seen a lot of cardiorenal syndrome, obviously, in that population. And so there's lots of collaboration with, for instance, nephrology and us moving patients down to ICMS in terms of CRT in the current status. Medical coverage, so like most intensive care units, there's an attending, there's a cardiology fellow, there are cardiology residents. However, the challenge begins at 1,700, as in probably many facilities. So after 1,700, 4 there's a senior resident and a junior resident that is on for the entire hospital. So it makes it challenging to page a physician at 2 a.m. to make the priority the ACCU patient when they have consults in emerge, they have patients on a medical unit, they have patients on 5A cardiology, they might have patients in ICCS, they might have patients in ICMS. So these are some of their challenges in terms of where their work will go. In terms of our environmental challenges for our current unit, we are on the 5th floor of the main hospital. Elevators are our bane of our existence because our beds perhaps don't fit like in the lovely elevators in the Asper that are quite spacious. So our challenges are moving patients. Our flow of patients, as you see, is from emerge, from cath lab back down to there as well. And so it makes it a challenge in terms of being able to move patients safely. We have in the more complex patient, we no longer transport our patients on our current beds. We transfer them to a stretcher, and that stretcher will actually fit in the E block, not the main where our CCU is, but in the E block off of medicine that will allow us to move a patient that has a balloon pump and a ventilator. And that seems to be working. The other challenges for those that when we first opened and came from other ICUs to care for patients, can you see the patient from where you're sitting outside in the hallway? It drives ICU nurses crazy till you work with us for a little while. So in the pictures that you can kind of see, this is actually the same patient as you're sitting outside the hall. They're actually ventilated. So if you're sitting at a certain place and you move forward, you can finally see the ventilator. So it does pose its physical challenges. You can sort of see here, again, this is one of our rooms that we use that oftentimes you'll see a ventilator will be tucked in that corner. So for nurses that want eyes on that tube at all times, drives you crazy, but you learn to work with it. And it's hard as well to see not only the patient, but the line. So if you're concerned about a patient that might be pulling on things, it does add some challenges because we have lots of walls. Everything in the unit, so we're what used to be would be a ward kind of hallway. So we are narrow, we are tight, and we are only 6 beds out of 10 right now, but everything has to be mobile. So our workstations in the hallway, as you can see, Christine and Nelson, as they're working, they have to be able to move because our nurses are usually typically 2 patients per nurse. That's our standard ratio, unless the patient's much sicker. But you can see, so it moves. We have exchange carts outside the room. They also can be moved as needed to sort of facilitate depending on where your patients are at. So our nursing challenges are, we have 6 patients and we are a standard of 2 to 1. However, there are the days when the patient is ventilated on vasopressors, we're chasing blood pressures. We have sick patients, they're on isolation. So Roseanne puts on her nursing shoes and her lab coat and she helps out. I also help out because sometimes it's really hard in the middle of a shift to now try a heavy workload. So those are our challenges, we're aware of that. And we all know the financial constraints that are happening right now in the region. So they're slow to go. We don't have a CRN, so we have a nurse in charge, so that nurse in charge will also have a patient assignment. So if we're at 6 beds, the charge nurse has 2 patients as well. So the key is teamwork, and we have the best team ever. So if you spend some time with us, we have lots and lots of challenges. However, because we have not one dedicated charge nurse, everybody has to know everything about how the unit runs, how to transport a patient out of province, how to transfer a patient to another site, how to get them back to whatever region that they're from. So we share information, we work on each other's strengths, we minimize the weaknesses, and we do have, I have to say, the best team ever. So what is next for ACCU? Well, we don't know where the road's going to go. If you ask the physicians, this is their wish list in the order they would like to see them come. TTM, so targeted temperature management. So taking those cooling patients that we're sending to ICMS for 24 hours, then they come to us. Impella patients, so that high-risk PCI that requires Impella, TAVI patients, CRRT, 6 beds to 10 beds, and then where we go from 3 nurses. So we don't know where we're going to go. Join us on our journey, Bill. And I leave it open to some questions.
That's sweet. Really good.